Thyroid disease. Endemic and sporadic goiter.Thyrotoxicosis. Thyroid disease. Endemic and sporadic goiter.Thyrotoxicosis. Clinical picture, diagnosis and treatment. Breast cancer. Acute mastitis. Dyshormonal disease breast. Palpation of the thyroid gland, isthmus. Palpation of the thyroid gland, right lobe. Palpation of the thyroid gland, left lobe. Palpation of the thyroid gland. Palpation of the thyroid gland. Classification of the goiter according to the form of enlargement. Diffuse goiter. Nodular goiter. Mixed goiter. The degree of enlargement. 0. The thyroid gland is not palpated. The isthmus of the gland is noticeable during swallowing and could be palpated. Entire gland is noticeable during swallowing and could be palpated. The enlargement of gland results in evident thickening of neck, a thick neck. V. The gland considerably enlarged and sharply deforms neck. V. The enlargement reaches excessive size, goiter of major sizes. Classification of the goiter according to the functional state. Euthyroid goiter, normal function. Hyperthyroid, excessive function. Hypothyroid, reduced function. Classification of the goiter according to the localization. Typical localization, anterior surface of the neck. Retrosternal goiter. Ectopic goiter, goiter of the base of tongue, intrathoracic goiter. Goiter of the additional glands. Presternal goiter. The nodular goiter of the third degree. The nodular goiter of the fourth degree. Goiter of major sizes. The goiter formation, intrathoracic goiter. Presternal goiter. Clinical manifestations of hyperthyroidism. Symptoms of hyperthyroidism include weight loss during normal or increased appetite, heat intolerance, excessive perspiration, muscle weakness, oligomenorrhea. Signs of hyperthyroidism include goiter, sinus tachycardia or atrial fibrillation, tremor, hyperreflexia, fine or thinning hair, muscle wasting. Clinical features of hypothyroidism include cold intolerance, weight gain, constipation, edema, especially of the eyelids, hands, and feet, dry skin, weakness, somnolence, and menorrhagia. Biochemical thyroid function testing. Currently, measurement of serum TSH level and free T4, FT4, is the best and most efficient combination of blood tests for diagnosis of most patients with thyroid disorders. Biochemical thyroid function testing. Measurement of TSH, 0.3 to 5.0 μ/L, by a second-generation sensitive TSH, SDSH, test is the single most useful biochemical test in the diagnosis of thyroid illness. In most ambulatory and hospitalized patients without pituitary disease, increased STSH signifies hypothyroidism, suppressed STSH suggests hyperthyroidism, and normal STSH reflects a euthyroid state. Biochemical thyroid function testing. Measurement of T3, 80 to 200 nanograms/dl, is test in hypothyroidism. This test is useful in the occasional patient with suspected hyperthyroidism, suppressed STSH. Biochemical thyroid function testing. Antithyroid microsomol antibodies are found in the serum of patients with autoimmune thyroiditis, Hashimoto's thyroiditis, and measurement of these antibodies is helpful to diagnose this common cause of hypothyroidism. Anti-TSH receptor antibodies, which stimulate the TSH receptor, are detectable in more than 90% of patients with autoimmune hyperthyroidism, Graves' disease. However, their measurement is not often needed in the diagnosis of this disease. Thyroid function test algorithm. A useful thyroid function test algorithm, ClinLab Med 13-673, 1993, includes STSHSA as the initial test. If this is normal, no further tests are needed. If STSH is elevated, FT4I and microsomol antibodies are measured to confirm hypothyroidism, which is often autoimmune. If STSH is suppressed, FT4I is measured to confirm primary hyperthyroidism. If TSH is low and FT4I is normal, T3 is measured to diagnose T3 thyrotoxicosis. Scanning of the thyroid gland. Scanning of the thyroid gland. Thyroid imaging is most often accomplished with radionuclide scanning or ultrasound. Other imaging modes, including computed tomographic, CT, scanning and microscan, are useful in special circumstances. Technetium thyroid scanning. Technetium thyroid scanning 20 minutes after the intravenous injection of technetium 99 meters, 99 mTC, is useful in determining the size of the thyroid and in differentiating solitary functioning nodules from multinodular goiter or Graves' disease. Hypofunctioning areas, cyst, neoplasm, or suppressed tissue adjacent to autonomous nodules, are cold. Areas of increased synthesis are hot. Cold nodules have a 15 to 20% risk of malignancy, most should be removed. Hot nodules are almost never malignant. 99 mTC thyroid scans are most useful as adjunctive tests to assess risk of malignancy in patients with indeterminate thyroid nodule cytology or in hyperthyroid patients suspected of having a hyperfunctioning thyroid adenoma. Thyroid scanning 4 to 24 hours after oral iodine 131, 131I, is useful to identify metastatic differentiated thyroid tumors and to both confirm a diagnosis of Graves' disease. Radionuclide thyroid scans of normal thyroid gland. Radionuclide thyroid scans of thyroid gland, goiter. Radionuclide thyroid scans of thyroid gland, diffuse goiter. Radionuclide thyroid scans of thyroid gland, diffuse goiter. Radionuclide thyroid scans of thyroid gland, nodular goiter. Thyroid ultrasonography with high frequency, 7.5 to 10.0 MHz. Thyroid ultrasonography with high frequency, 7.5 to 10.0 MHz, determines gland volume as well as the number and character of thyroid nodules. Although not completely reliable, features suggestive of malignancy on ultrasound include hypoechoic pattern, irregular margins, and microcalcifications. Ultrasound is useful to guide fine needle aspiration, FNA, biopsy and cyst aspiration. Cysts seen on ultrasound, especially those larger than 3 cm, are malignant in up to 14% of cases. Nodular goiter. Cyst of the thyroid gland. Punction of the cyst of the thyroid gland. X-ray examination, CT scanning and microscan. X-ray examination, CT scanning and microscan of the thyroid are costly and generally are reserved for assessing substernal or retrosternal masses suspected to be goiters. Retrosternal goiter. Retrosternal goiter, X-ray and CT. Retrosternal goiter. Retrosternal goiter. Retrosternal goiter. Retrosternal goiter. Retrosternal goiter, electro X-ray. Retrosternal goiter. Termogram of the goiter. Trachea deformation. Complication of the goiter, tracheomalacia. Autoimmune diffuse toxic goiter, Graves' disease. Autoimmune diffuse toxic goiter, Graves' disease, is the most common cause of hyperthyroidism and may be caused by stimulating immunoglobulins directed against the TSH receptor. Graves' disease may be treated with antithyroid drugs, ablation with radioactive iodine, RAI, or surgery, depending on the clinical situation. Diffuse goiter. Diffuse goiter. Diffuse goiter. Diffuse goiter, pathological exophthalm. Pathological exophthalm. Pathological exophthalm. External signs of the thyroid gland diseases. Treatment of the Graves' disease. Tinamide drugs, such as propylthiouracil, PTU, or methimazole, are the initial therapy in most cases. PTU, 100 to 300 mg POTID, is given for 4 to 6 weeks until the patient becomes euthyroid, then the dosage usually is decreased. PTU, 100 mg POTID. The patient is then treated empirically for 6 to 18 months, at which time the drugs are withdrawn. Clinical features that favor remission include small gland size and mild hyperthyroidism of recent onset, although overall, long-term remission is achieved in less than 20 to 30% of patients. Treatment of the Graves' disease. Antithyroid drugs also are used to prepare thyrotoxic patients for surgery or ablative therapy. PTU may be given during pregnancy at reduced doses, especially if thyroidectomy is necessary in the second trimester. Minor adverse reactions occurring frequently and include rash, hepatitis, arthralgias, and a lupus-like syndrome. Agranulocytosis is a rare, 0.5%, but serious side effect of tinamide therapy. Treatment of the Graves' disease. Ablation with RAI is the treatment of choice for most patients with Graves' disease. A dose of 5 to 10 mc of 131I is given orally and is 75% effective after 4 to 12 weeks. In the 25% of patients with persistent thyrotoxicosis after 12 weeks, double the initial dose is repeated. After treatment, there is a high incidence, 70%, of eventual permanent hypothyroidism, which is managed easily by replacement therapy. There are virtually no other long-term side effects of RAI, i.e., no significantly increased risk of thyroid cancer, leukemia, or teratogenicity. Treatment of the Graves' disease. Ablation with RAI is the treatment of choice for most patients with Graves' disease. Contraindications to radiotherapy include pregnant women, newborns, patients who refuse, or patients with low RAI uptake, less than 20%, in the thyroid. Treatment of children or young adults, younger than 30 years, with RAI is controversial because of presumed long-term oncogenic risks. Thyroidectomy for Graves' disease. Thyroidectomy for Graves' disease may be indicated for children or patients unresponsive to medical therapy, or patients who refuse RAI. A bilateral subtotal thyroidectomy should be performed with the goal of leaving a 1 to 2 gram vascularized cuff of thyroid on each side. However, some centers advocate total thyroidectomy as primary treatment to decrease recurrence rate of goiter's disease. Risks of surgery are extremely small, less than 1%, in experienced hands, but include hypoparathyroidism and injury to the recurrent laryngeal nerve. Subtotal subfacial resection of the thyroid gland. Operation. Retrosternal goiter. Resection of the thyroid gland. Operation right side hemithyroidectomy. Subtotal subfacial resection of the thyroid gland. Thyroidectomy for Graves' disease. Surgery results in hypothyroidism less frequently than does RAI, in Engelgeme at 311 to 426, 1984. The long-term incidence of recurrent hypothyroidism after surgery is approximately 10%. Patients with recurrent hypothyroidism after thyroidectomy should be treated with RI. Management of complications after thyroidectomy. Hemorrhage is a rare but serious complication of thyroidectomy that usually occurs within 6 hours of surgery. Management can require control of the airway by endotracheal intubation and can rarely mandate urgent opening of incision and evacuation of hematoma before returning to the operating room for wound irrigation and ligation of the bleeding point. Management of complications after thyroidectomy. Transient hypocalcemia commonly occurs 24 to 48 hours after thyroidectomy but infrequently requires treatment. Patients who are markedly symptomatic or who have serum calcium below 7 mg/dl are given 1 to 2 ampules, 10 to 20 milliliters, of 10% calcium gluconate IV over 1 to 2 minutes followed by temporary oral calcium carbonate, 500 mg POTID. More prolonged intravenous replacement is achieved by mixing 6 ampules of 10% calcium gluconate, 540 mg elemental calcium, and D5W, 500 ml, for infusion at 1 ml/kg per hour. Permanent hypoparathyroidism is uncommon after total thyroidectomy. Normal parathyroid tissue removed or devascularized at the time of total thyroidectomy may be autotransplanted into sternocleidomastoid muscle to prevent postoperative hypocalcemia. Management of complications after thyroidectomy. Recurrent laryngeal nerve, RLN, injury is a devastating complication of thyroidectomy that should occur rarely, less than 1%. Unilateral RLN injury causes hoarseness, and bilateral injury compromises the airway, necessitating tracheostomy. Repeat neck expiration, thyroidectomy for extensive goiter or Graves' disease, and thyroidectomy for fixed, locally invasive cancers are procedures particularly prone to RLN injury. Intentional, as with locally invasive cancer, or inadvertent transection of the RLN can be repaired primarily or with a nerve graft, although the efficacy of these repairs is not known. Temporary RLN palsies can occur during thyroidectomy, and these usually resolve over a period of 4 to 6 weeks.